So radial head fractures are common, as you know, and the etiology can be a fall on the outstretched hand with the pronated forearm, an extended elbow, or a direct blow, or the radial head fracture can be part of an elbow dislocation, with, of course, ligamentous lesions. Indeed, associated lesions are quite frequent with radial head fractures and can involve the medial collateral ligament, especially in the case of an elbow dislocation. There can be also a fracture of the capitulum, but most frequently cartilage impaction at this level. There can be a rupture of the forearm interosseous membrane, usually with distal radioulnar joint dislocation, leading to what is called a arthroplasty lesion. There can be also a fracture of the scaphoid. The classical treatment of non-displaced or minimally displaced radial head fractures is by early mobilization, sometimes with aspiration of the joint. The classical treatment of displaced radial head fractures is by resection of the radial head and early mobilization. However, there are problems. Non-union can be seen after conservative treatment, while instability is seen after radial head resection. And concerning instability, let me remind you about the primary and secondary stabilizers of the elbow to a valgus stress. This nice study by Murray showed that if you simply resect the radial head in green, there is not much change of stability of the elbow. If you then section the medial collateral ligament, then there is marked instability of the elbow, which dislocates. If, on the reverse, you first section the medial collateral ligament, there is frank instability of the elbow, however limited by the preservation of the radial head, and the same, of course, dislocation of the elbow appears after resection of the radial head. So this is the classical concept of Murray, that the medial collateral ligament is a primary elbow stabilizer to a valgus stress, the radial head being the secondary stabilizer. Indeed, what is important in the medial collateral ligament complex is the anterior band in yellow on this picture, not the posterior nor the transverse bands. And especially the anterior part of the anterior component. And this is illustrated illustrated in this nice biomechanical study by Flores. Indeed, lateral instability can occur after radial head resection and can impose reconstruction of the ligament if it is not sutured at the time of the trauma. Biomechanical studies have shown that radial head arthroplasty can restore elbow stability, but less efficiently than ligament repair. Full restoration is obtained by ligament repair and radial head arthroplasty, and Pomianowski demonstrated that bipolar arthroplasty is as efficient than unipolar to restore stability. But unipolar could be better in the case of deficient soft tissues. Another problem is the axial stability, and in the case of a lesion of the interosseous membrane, then can be the arthroplasty syndrome with proximal migration of the radius, usually after resection of the radial head, usually with distal radioulnar joint dislocation, and of course ulnocarpal impingement, as you can see on this clinical example. The recent study of Schiffern has shown that the migration is not only proximal but also posterior and medial, especially in the case of an initial dislocation of the elbow. And after radial head resection, you have progressive valgus deformity leading to tardive ulnar palsy, which can impose ulnar nerve transposition. And also, most studies show that after several years after radial head resection, you develop late humeroulnar osteoarthrosis. We could show in this study that we published several years ago that only one quarter of the patients are devoid of osteoarthrosis at the ulnohumeral joint after radial head resection. Other problems have been seen, including capitular demineralization, radial head partial ossification or heterotopic ossifications. We had also a cubitus valgus deformity in most patients, and also many problems at the distal radioulnar joint in these patients. And the clinical results were not so good because only 1/3 of the patients were devoid of pain. Many patients had restricted elbow motion and also loss of strength. And they had also valgus instability for 54% of the patients in these series. The MAPS was 79 on average, which is good, but excellent is over 90 points. Other studies have been published, not so many in literature, showing, however, some better clinical results, but the constant is the presence of osteoarthrosis in the humerohumeral joints. So to prevent all these problems, we should probably perform osteosynthesis of simple or relatively simple fractures and do hemiarthroplasty in the case of marked comminution. Osteosynthesis provides very good function in the case of a stable fixation with immediate mobilization. We now use very less bulky implants than in the past. This is a series that we published, and we found that 87% that the mean MAPS was 87. That 52% of these patients had excellent results. So the results are good, but not perfect. And recently, the group of Ring has discussed about the necessity to fix simple Mason 2 fractures which are not very much displaced. And other groups have recommended arthroscopic screwing. Indeed, the results are not always favorable, especially when an anatomical reduction is not obtained or if the fixation is not stable or inadequate, like in these examples. This case was sent to me for radial head osteosynthesis, and but when you trace the axis of the radius, you see that there is a problem. When you see the elbow, there is a problem. And actually, this patient had no fracture of the radial head, but a fracture of the coronoid associated to a missed dislocation of the elbow. This is a case of radial head arthroplasty in a case of comminuted fracture, and we use the cemented prosthesis of Judet, which is a bipolar prosthesis. Another example in comminuted fracture of the radial head, we always do a CT scan to understand better the lesion and to see if it is reconstructible. We resect the radial head progressively in order to perfectly adjust the length of the radius with the prosthesis. This is the prosthesis in place, and the result was very good for the motion of the elbow, but the patient developed some hand CRPS. And of course, such prosthesis can be done as part of a complex elbow reconstruction. What about long-term clinical results? Where we see complications, like this patient operated elsewhere, prosthesis properly not well implanted, and the patient had pain and a painful subluxation. And this patient was operated in our unit. He developed a septic loosening, and we had to remove the prosthesis. And this is a patient who has been operated several times of radial head prosthesis elsewhere. And later on, he had a problem at the distal radioulnar joint. They did Sauvé-Capenghi. And when I saw him, he had a painful posterior dislocation of the radial head prosthesis and also pain at the conflict between the ulnar stump and the radius. So at the end, we had... I don't know how to get the video. I'm sorry, I don't know how to go on the video. Can you go click on the videos, please? Because I cannot advance. Can you click on the videos, please? The too little on the down. Yeah, okay. And then, I'm sorry, I cannot. Can you move the next slide, please? And at the end, anyway, we had to do in this patient a one bone forearm to solve the problem, which should be shown in the next slide. Next slide, please. Next slide, please. I'm sorry about that. Yeah, that's the one bone forearm. Okay. So there are many potential complications of radial head arthroplasty, including disassembly, heteropediculosification, CRPS, and also a very important complication is capitular erosion with subsequent osteoarthrosis in the case of prosthetic overstuffing, as you can see. So there are many questions about arthroplasty of the radial head. We did a biomechanical study that our group published last year in the Journal of Shoulder and Elbow Arthroplasty, studying the contact after bipolar prosthesis. And we used this casting material. And what we found actually is that the contacts at the prosthetic capitular joint are much better with the bipolar prosthesis than with the unipolar prosthesis, and that the prosthesis really adapted to the capitulum. So these prostheses could maybe prevent capillary erosion over time, and this is important because we implant these prostheses in very young patients. However, we found other problems, including some contacts with the trochlea that is illustrated on this picture. If you review the clinical literature, there are many studies published. I think that the results are similar, maybe a little bit better, but of course it was not prospective comparative studies, a little bit better for the unipolar prosthesis, with a specific problem with this prosthesis, which is stem loosening. But of course, many times this loosening is deliberate when this prosthesis is used as a spacer. In all series, you find complications, including osteolysis and loosening, also dislocations, capitular erosions, and osteoarthrosis in most patients at the humeral-ulnar joints. So in conclusion, early mobilization or stable internal fixation is recommended for simple radial head fractures. For comminuted radial head fractures, radial head resection is still a good option because the rate of osteoarthrosis is not less with prosthesis at the ulno-humeral joint, and there are problems with prosthesis. But of course, in the case of associated ligament lesions, radial head arthroplasty is mandatory. It is important, of course, to reconstruct the ligaments as well if possible. We feel that the Judet-cemented bipolar hemiarthroplasty allows better contact, which could prevent in poor capitular cartilage degeneration and offer better stability. But the clinical results, we must recognize, seem quite comparable. What about the future? These prostheses are implanted in very young patients. We don't know. We must be cautious for the future. I have no experience of total arthroplasty or capitular resurfacing. And is there a remaining place for silexic implants? Interestingly enough, when you read the literature, the results are not so bad as has been stated, with not so many problems of siliconitis. And in chronic situations, the literature shows that in radial head non-unions and malunions, we can obtain good results with arthroplasty, but the results are poor in extroplasty lesions, which is, of course, the most difficult problem to solve, which is really, at the present time, unsolved. So thank you very much for your attention. And I don't know if my co-moderator is here. No, it seems not. Some questions for me before we go on? Yes, please?
Yes. What are the consequences if you simply reject broken radial head instead of arthroplasty?
Pardon me? If you simply resect?
Yes, if simply resect radial head instead of arthroplasty.
Yeah, I don't know if you were at the beginning of my my lecture, but I presented the result of a study that we did in the past. The results